Today, we are on site in Orlando, Florida at the Community Oncology Alliance's annual Community Oncology Conference. We will be recapping some of the top news presented each day during the conference, and soon we'll speak with Ted Okon, Executive Director of COA, and Dr. Sibel Blau, Medical Director of Northwest Medical Specialties, about different trends and policies impacting oncologists and their patients. Welcome to AJMC On Location. I'm Jamie Rosenberg. With the theme of ensuring quality, affordable, and accessible cancer care, the meeting kicked off today with a look at how cancer care delivery is transforming, with sessions focused on the evolution of payment models and the impact of different healthcare policies. The future of cancer care was on display, first with a session on artificial intelligence and community oncology. There was also a session highlighting COA's OCM 2.0, a proposed model that builds on CMS's oncology care model. Finally, a session in the patient advocacy track looked at how community oncology is shaping the future of cancer care by bringing clinical trials into the community setting. Read coverage and watch additional interviews from the meeting at ajmc.com. Here with me now is Ted Okon of COA. Thanks so much for being here today. We're excited to have you.
Sure, Jamie. It's a pleasure.
So to start off, we know a large focus of the Trump administration has been on drug costs. And over the past year, they've introduced different legislation to try and address these costs. And one rule that has taken effect is the inclusion of drug prices in television ads, and Johnson & Johnson is poised to be the first company to do so. So do you think this will have a positive impact on drug prices, and are there any unintended consequences you foresee occurring from this?
Well, you know, this is a little bit of a mixed bag. I'm all into transparency, and I think transparency is important. But the question that comes up, what price are they going to put? I mean, we have this situation now where there are list prices which are artificially high that patients pay for, and then there are real net prices. And so it's a little problem with that. And you know, I'm a big fan of Dr. Mark Fendrick at the University of Michigan, and Dr. Fendrick always says it's not what the price of the drug, it's what the patient pays. So are they really going to put up what the patient pays? They can't, because patients pay all types of different prices. So I think that's part of the problem here. I think transparency is great. I really give J&J props for actually starting this out, but it's a little question of how this is going to end up in terms of really truly affecting bringing down drug prices. I think it is one step in the right direction, but it remains to be seen if it will really work.
So another proposal put forward by the administration is the Medicare International Pricing Model for Part B drugs. And this proposal has had a little more pushback from stakeholders. What are some concerns that stakeholders have with this?
Well, there are three parts to this. The first part that I think the pharmaceutical industry has the biggest problem with is the idea of indexing prices in the United States off of other countries. And I think there's some concern in terms of what will happen, the games that other countries will play. But what I'd like to focus on for a minute is basically the two other portions of this. The one is called the Competitive Acquisition Program. And what that would do is it would fundamentally alter how cancer patients get their drugs. So instead of actually the practice actually bringing the drugs in and the cancer patient have just-in-time access for those drugs, especially when one drug isn't doing the job for their chemotherapy and they have to be switched to another drug, the bottom line is what would happen is they'd have to order a drug from some middleman. You bring these middlemen in, and we have a big problem with pharmacy benefit managers and other middlemen who basically getting in the way between the doctor and the patient in terms of deciding their care. So I think that's a real problem, and we have voiced strong opposition to the cap. The other thing is changing the dynamic of the reimbursement formula. You know, unfortunately what the government has done, especially with sequestration or the automatic ratcheting down of Medicare, is they've done that to such a degree that we see community practices that have merged into the hospital or have gone out of business or closed facilities. So the other portion of this, what's known as the IPI model, is actually changing the reimbursement formula. That has had an adverse effect already on cancer care, and it will have an additional adverse effect. So we believe, though, instead of not saying all the time, no, that won't work, we've actually proposed some alternatives. And those alternatives have to deal with actually putting the decision-making back in the hand of the physician along with the patient, and having a more realistic approach to the reimbursement formula, the Medicare payments, what Medicare pays for these cancer drugs.
So something you mentioned were these pharmacy benefit managers, and that's also been a focus of the administration, and also what Azar and others have been calling the secretive rebate system. So what are your thoughts on the proposal to overhaul the system, and do you think this will largely address drug costs, or this is just one piece of the puzzle?
This is really important. I think the fact that these pharmacy benefit managers, what they do in terms of fueling drug prices, look, make no mistake about it, it's the pharmaceutical companies that set the price. Those prices have to come down, but they are fueled by this secretive, murky rebate system that these pharmacy benefit managers, the PBMs, actually extort from companies. And I think this is a real problem. I am so glad that Secretary Azar has gotten involved in terms of taking these rebates away, in essence making them illegal, and having any discounts go directly to the patient. Look, pharmaceutical companies say that if you basically take the rebates away, we will lower list prices. There was a Senate finance hearing where 7 executives from pharmaceutical companies said that, stated that. They're on the record under oath. So if you take those rebates away, we have to see drug prices go lower. The other thing that's really gratifying now is there are a number of members of Congress that are working on a bill. There's actually one bill out already that would take away rebates in the commercial market, not just with Medicare and Medicaid, but in the commercial market. What that will do, I think, is it's a stepping stone, but it will put companies on the hook for basically lowering their prices, and it will get these middlemen who are atrocious. They're adversely impacting patient care, and they're fueling drug prices, get them out of the way.
Great. And so shifting gears a little bit, there's been a lot of news in the past week about the Affordable Care Act, including the Department of Justice siding with the judge who struck down the ACA. So as the ACA continues to face legal battles, what do you think the impacts would be on cancer patients if this was overturned?
Well, you know, one of the things is pre-existing conditions. So if you're a cancer patient, you have a pre-existing condition, and trying to get insurance, that's really impossible. The other thing is that if they overturn the whole law, it would do away with the Innovation Center, okay, the Center for Medicare and Medicaid Innovation. We're big supporters of that. There's a model ongoing right now, the oncology care model, of the practices, about 200 practices are participating in. We're backing it in a big way, and it's not perfect, but we're making changes as we go along. It would do away entirely with the CMMI. I am totally against the Trump administration trying to, and by the way, a lot of Republicans now against basically doing away with the ACA. What should happen is we should, on a bipartisan basis, look at this and saying what's working, what's not working. There are parts that aren't working. There are parts that are working. And instead of just leaving people out in the cold, especially with pre-existing conditions, what we should be doing is looking at this in a rational way and say, let's fix it. Let's make it better.
Right. And are there any other policies you're keeping your eye on in the coming months or the next year or so?
Oh, there are so many policies, I don't know where to start. You know, one of the things we've just commented on officially to CMS is on CAR T. So you have these very expensive therapies, only a couple out, but more coming, and basically CMS came out with a national coverage determination or a proposal to basically how they would cover these therapies. And one of the things that we've said is, look, these are really serious therapies, but the fact of the matter is you have community oncology practices, very sophisticated practices that are on clinical trials with these therapies, that are actually using these therapies, and they should be allowed in part of the process, because one of the proposals that CMS said is it would only be hospitals. So that's something we're working on. We're waiting for a model, a demonstration model on radiation therapy. We're a little nervous about that, but we've already commented that we would like to sit down with CMS and we would like to bring in some radiation oncologists and talk about a model that incorporates the opinion of actual radiation oncologists. It's not just the bureaucracy in DC coming up with these models. So I could sit here and go on and on and on. There is more that has come out that's tied to the president's blueprint. There's more politics that are going on, as you know, in Washington, DC. But I think we can probably cut it there and talk another time.
Perfect. Thank you so much.
You've got it. Bye-bye.
So here with us now is Dr. Sibel Blau of Northwest Medical Specialties. Hi, Dr. Blau. Thanks so much for being here with us.
Hi, thank you.
So earlier today you had a talk on artificial intelligence in community oncology. How can these applications be used by oncologists to better understand and in turn serve their patients?
Well, as I explained this morning on the panel, we were an early adopter of an artificial intelligence tool to help us identify the high-risk patients for either emergency room or hospital admissions, or 30-day mortality and morbidity in general. By using a tool, the doctors get alerted to see their patients in the clinics and assess the problems they might be facing. By using the tool, by being a doctor, with the help of the tool, you can identify the patients at risk earlier on and intervene to reduce mortality and morbidity.
Perfect. And in addition to help guide treatment for patients, can these applications also be used to predict different outcomes?
Well, this is exactly what actually I said. I really believe that even though one of our vectors, for example, is a 30-day mortality vector, even though a lot of patients are at the end of their life and the 30-day mortality may be an indication to that as they show up on the list showing high risk for that mortality risk. But some of that could be preventable death, preventable illness by identifying those patients. So the outcomes could be changed and improved, both by making the patients get benefit from the correct treatment, and also to reduce the cost by intervening these patients earlier on in the clinic setting and avoiding the hospitalizations and emergency room admissions.
And where do you think we'll be with artificial intelligence in 5 years? And what are some of the biggest hurdles community oncologists have to kind of get through in order to get where we want to be in those 5 years?
Well, the first question's answer is that I think this is going to take off very fast. As a technology is doing it these days, we have so many tools out there to help us in our clinics with the data analytics and everything else. But the biggest challenge, I think, is the cost, because smaller practices cannot afford very high cost tools, which we all need. We need different tools to be able to provide a better care and analyze what we do to improve the quality of care for our patients, while focusing on the cost issue for the care of that patient. But it's costly for the clinics. I see that would be one of the major challenges.
And last year, the Quality Cancer Care Alliance created the first clinically integrated network in oncology in the US. How can artificial intelligence be leveraged by QCCA to determine more effective and more cost-efficient ways of improving quality of care?
Well, in order to be a true clinically integrated network, certain things need to be shared and done at the same level by diverse practices throughout the country. QCCA network provides that framework, but we needed an infrastructure to build those tools to be able to provide that unified care, higher quality and lower cost care, and show it to the payers and patients. Most importantly, to the patients, give that quality of care. So for that, we needed to start a management service organization, and 2 days ago we announced it. Actually, it's called IQ Oncology. Our idea is to develop that infrastructure that will need the tools to serve the patients with the cutting edge technology, research, and clinical care. So I see, the moment I started working with the AI tool, I saw that as an opportunity to improve risk stratification for our patients, to reduce the emergency room admissions and hospital admissions. That was my very simple idea at the time. I can see even more benefits. Like I said, you can actually intervene in the care of the patient proactively and improve the outcomes. So I see this as one of the very important tools for our value-based care organization we're creating. And then we're going to incorporate some form of our artificial intelligence tool in our MSO.
Great. And in addition to artificial intelligence, what other methods does QCCA use to support value-based care?
I think I answered this also a little bit earlier. It's a lot of tools, and we are really focusing on data, anything related to data, to be able to analyze the data that we get from Medicare and other alternative payment models, to share, report, collect, and bring some interventions based on those data. So for that, Quality Cancer Care Alliance Network, IQ Oncology will bring this framework to build all this in there. And clinical pathways, triage pathways, practice transformation that's really needed to provide the true value-based care organizations base are going to be very cornerstones of the organization.
Great. And I have one final question for you before I let you go. So as you mentioned, QCCA earlier this week launched IQ Oncology, its management services organization. How will IQ Oncology build upon and complement QCCA's clinically integrated network?
I think I also answered that earlier, but I'll reemphasize it. I think this is the most important thing for us, for independent oncology practices who cannot afford the tools that are needed in today's world to improve the value-based care. And as the IQ Oncology bring the funding and the tools into the management service organization, its main goal initially is to create that value-based care organization's needs. Well, it will eventually move into other parts of the practice benefits, and there will be some a la carte services in it. But really the focus initially is going to be all about around data, pathways, and building this value-based care organization.
Great, thank you so much.
Thank you for the opportunity.
That's all for today. Stay tuned for tomorrow's AJMC On Location, where we will sit down with Dr. Deborah Patt of Texas Oncology about the opioid epidemic and 340B, and Dr. Jeff Asurka of New York Cancer and Blood Specialists about challenges facing community oncologists and how One Oncology is addressing those challenges. Thank you for watching AJMC News Network. I'm Jamie Rosenberg.